Hello, everyone. My name is Dr. Asin Hussain. I'm an assistant professor in ophthalmic, plastic, and reconstructive surgery at Dalhousie University in Halifax, Nova Scotia. Thank you for joining us today. We'll be speaking about benign essential blepharospasm. So just to give you some historical perspective, first of all, on this very interesting condition. In 1910, Meige, spelled M-E-I-G-E, first described unilateral facial spasms. And there's interesting art history demonstrating Tourette syndrome and facial spasms, which you may be interested to look up. Urist in 1957 brought to specific attention the problem of bilateral blepharospasm in 1957. And actually he described how injection of absolute alcohol over the facial nerve as an alternative to neurectomy could be used as a treatment for this condition. And in 1933, Parker in the American Journal of Ophthalmology described the association between blepharospasm and Parkinson's disease, which is an important consideration when you're seeing patients. So the etiology of this condition, well, we know that it's idiopathic. It is unclear where the process originates from. It is possibly a thalamic, basal ganglion, mesencephalic, or a brainstem origin. And as mentioned, it can be associated with other movement disorders, such as Parkinson's disease. The epidemiology of the condition, the mean age is about 56 years, and women outnumber men for this condition by 3 to 1. And the patient usually complains of episodes of bilateral blepharospasm. Usually it's bilateral. If it's unilateral, you should potentially think about investigating the patient further. Particularly if it's related to a hemifacial spasm and unilateral. The typical history, though, is the spasms last for seconds to minutes, and then there's a degree of improvement. The progression can be asymmetric. In some people, the disease can result eventually in apraxia of eyelid opening, and they cannot open their eyelids in about 12% of patients. And the condition can actually progress to include the mid and lower facial muscles too. What is important to differentiate this condition with other dystonias and facial movement disorders are that the blepharospasm spasms, sorry to say that, but the BEB spasms are not present during sleep. Also, just be aware that you could be referred patients for ptosis or dramatic chalasis when in fact they have evidence of overt contracture and apraxia of eyelid opening, which may be very subtle findings, which I've seen myself. So clinical features, well, first of all, in terms of a general history, the patient is very disabled by this usually. That's why they come in to see you. This can result in inability to work or drive and can result in visual and systemic limitations. People who are really incapacitated can find that they really cannot live their life. I've had patients who are almost suicidal and they have to pry their eyelids open with their fingers. Look for associated anatomical problems that accompany the BEB, such as brow ptosis, blepharoptosis, pseudotosis, associated levator disinsertion, dramatic chalasis, eyelid malposition, such as entropion or ectropion, eyelid phimosis, and also look for punctate epithelial keratopathy, so an evidence of dry eyes, which of course will potentially make their spasms much worse. The patient may describe triggers such as sunlight, stress, wind, noise, eyelid movement, reading, and even fatigue. And some patients even learn techniques to diminish the spasms known as geste antagonistique, such as tongue thrusting, pressing at the temples, humming, and of course we know sleep and rest can improve the symptoms. And patients can either remain stable over the years or they can progress to severe incapacitation. We've already mentioned Parkinson's disease, and in a study in 2012 by Rana in the European Journal of Neurology, 28 blepharospasm patients were in 28 patients, the most common systemic neurological association was Parkinson's disease in a Toronto clinic where that study was performed. And we won't talk too much about Parkinson's, but we know that it's a very common systemic disorder marked by hypokinesia, resting tremor, and rigidity or postural instability. So if you have a patient coming into your clinic with those signs, even as they walk to your consultation chair, be aware of whether they have Parkinson's or whether it needs investigation. An important consideration is that some patients with Parkinson's and blepharospasm can progress to supranuclear palsy, and that can result in increased risk of falls. And this is a very important social consideration in patients who are living alone or with less help. So how do you test for this? Well, really the diagnosis of a BEB is based on your clinical findings through the history and examination. There has been a research tool in that the PET scans have demonstrated abnormalities in cortical and subcortical areas that control linking. And there have been clusters of increased glucose uptake in certain parts of the brain, such as the frontal and posterior gyri. And there have been subcortical abnormalities also seen. Refer these patients for neurological evaluation if you feel this is more than just your benign form of blepharospasm. And if you see a patient with bilateral severe hemifacial spasm in particular, you should have a low threshold for neuroimaging. In fact, I had a patient who recently responded fairly well to treatment with botulinum toxin, which we'll come to on one side, but on the other did not do very well with that treatment. And further investigation actually revealed the presence of hyperintensities in the motor facial pathway, which we diagnosed and referred this patient to a neurology and awaiting that consultation. So differential diagnosis, well, think about hemifacial spasm, which can in itself have a neoplastic or vascular etiology. Think about aberrant regeneration from facial nerve palsy. So always ask about whether the patient had a Bell's palsy or trauma or surgery at the brainstem or the vicinity of the facial nerve, which may have then resulted in secondary aberrant regeneration. Think about apraxia of eyelid opening. This is a non-paralytic inability to open the eyes in the presence of visible contraction of the orbicularis oculi muscle. And in this condition, the patient demonstrates persistent septal and pretarsal orbicularis activity, which can be shown on EMG. There is also a latency to onset and complete eye opening, demonstrating that the levator is probably also inhibited in this condition. Think about orbicularis myokymia. That's a differential. That is localized twitching of a particular portion of the orbicularis muscle, which is quite common. In fact, I had some after I had too much caffeine over a week or so. And on stopping the caffeine, actually, the coffee, it actually improves simultaneously. But in these localized contractions, this might be related to caffeine, stress, physical exertion, fatigue, lack of sleep. And then think about reflex blepharospasm to do with significant dry eye, anterior uveitis, which can also be resulting in photophobia, and actually some systemic medications which can cause facial dystonia. So we know that certain neuroleptics in the management of schizophrenia can cause facial dystonias. How do you manage these patients? Well, the natural history of these conditions is that unless you have certain factors which are worsening the condition, such as trigger factors, if they're controlled, you might reduce the incidence and severity of the blepharospasm. But most patients usually require some form of treatment. And there was an interesting study at the Wilmer Eye Institute in 1998, where they looked at 238 patients with essential blepharospasm, and remission was observed only in 11% of patients, with the intervals from presentation to remission ranging from between 3 months to 22 years. And the gold standard of treatment that we now have is medical therapy, which is onabotulinum toxin. This is a toxin produced by a bacterium, Clostridium, and it's important to know how this medication works. This can be in your exams, so you can look that up. It's very important, and this medication is injected to reduce the production of acetylcholine at the neuromuscular junction. I beg your pardon, reduce the production of acetylcholine, and that results in some paralysis of that muscle. The therapeutic effect is about 3 months. It is injected subcutaneously in the upper and lower eyelids. People differ in the patterns of how that is injected. I myself have my own patterns, and I usually inject in a pretarsal area. You avoid the sort of higher sites in the upper lid to avoid causing ptosis through levator paralysis. The normal injection units are about 2.5 to 5 units. The onset of effect is about 2 to 7 days. I ask patients not to massage or cold compress the site so that the medication is not dispersed further. And then I sort of, for the first injection, after that, I see the patient 2 weeks after to review how successful it was and whether we need to change the sites and volume of injection. There are other medical treatments such as muscle relaxants systemically, such as orphenadrine, which can be used to relax the muscles in mild cases of blepharospasm. Ritalin has also been used, which is a methylphenidate in a small series in OPRS into 2010. There was a subjective improvement in 13 out of 14 patients, and that can be used as a medication as well. In terms of surgery, this is usually reserved for patients who have significant severe symptoms despite high doses of botulinum toxin. You can perform a protractor myectomy, which includes the orbicularis oculi, the corrugators, and procerus. But usually now it is mainly localized to the orbicularis muscle. And this is usually, as I say, reserved for patients who have inadequate response to the botulinum toxin. And most patients still require botulinum toxin, albeit at a decreased dose and frequency. And that was confirmed in a paper in OPRS by Kent in 2015. We won't talk about the surgical technique of that. That is for another day. And selective facial neurectomy is another old school treatment. Historically, that was the first line. The success rate has been considered to be 50% initially, but then a nerve regeneration and aberrancy can make actually the situation worse than it was preoperatively and result in a very worse blepharospasm picture, meaning that the patient requires further intervention. And there are now studies targeting specific branches, such as a zygomatic branch, but again, abnormal eyelid function and perioral muscle weakness can result. You should think about other considerations in management. These are the sort of early considerations that I talk to patients about, such as getting an FL41 tinted glasses. Some people benefit from biofeedback or hypnosis, improving sleep hygiene, reducing caffeine, increased hydration. All these done together with the other sort of management considerations can be useful. And patients who have apraxia of eyelid opening, they may actually benefit from levator advancement, frontalis sling surgery. And there have also been some studies looking at doxorubicin chymomyectomy as a treatment for blepharospasm, described in Ophthalmology in 1998. And that is really reserved for very resistant disease. Complications, well, relating to the medication, the botulinum toxin, you can cause ptosis, diplopia. That is something you should talk about it during the consent process. Legophthalmos, dry eye considerations, superficial keratitis. And if you get a patient with severe ectropion from botulinum toxin, that may require surgical intervention if it's persistent. Myectomy may result in secondary adverse sequelae such as exposure keratopathy, lymphedema, and eyelid malposition. You can also cause necrosis of overlying skin from very aggressive removal of the vascular orbicularis tissue. And also, of course, leg ophthalmos, leg retraction, and eyelid malposition. And with regards to, selective nerve destruction, as we mentioned, in patients who have that performed, there is a high incidence of lid malposition, aberrant regeneration, and secondary complications from that treatment. With regards to the disease itself, we know that although intraocular pressure can increase as much as 100 millimeters of mercury with forced eyelid closure, the likelihood of developing glaucoma in these patients is low. And that was a study performed by Lee and OPRS in 2010. But of course, the disease can result in significant visual dysfunction and lifestyle limitation, and also cosmetic deformity with spasms, excessive blinking, and secondary periocular changes such as dramatic chalasis, which the patient then may require intervention for. Okay, and that's the end of that case.